Online etiquette and convention reminder.
Background noise. See that there's no disturbance like background noise or people moving around to avoid distractions. Sit in a good lighted and noise-free room.
Test equipment and internet speed. Check the laptop or desktop before joining the webinar. Choose a spot with an unlimited and strong internet connection. Use headphones or earphones to reduce the background noise.
Log in on time. Be on time. Join every session at least 10 minutes prior to the session. Value other people's time.
Mute your mic and camera off. Please put your microphone on mute and camera off during the session to avoid interruption of the presentation. Be polite, do not interrupt.
Leaving the session. Do not close or leave the Zoom app during the session to avoid being logged out that will result to incomplete attendance.
Asking questions. All questions will be entertained after the presentation. You may type your question on the chat box so that the moderator can take note of it. Keep your questions minimal and on the topic.
Be prepared for technical difficulties. In case of technical glitches, kindly send us a message through the email or social media outlets or through SMS.
Profile and display name. Choose a suitable profile picture. Name yourself formally the way you want to present yourself.
Certificate of Attendance. Certificate of Attendance will be given only after the participant has accomplished the daily evaluation after the daily session. Links will be showed on the screen and on the CCNAPI website. Kindly wait for 7 to 14 working days to receive your certificate.
Self-directed learning application. Self-directed learning may be applied for those who cannot complete the 4 days main convention. An application form for the self-directed will be included with your daily certificate.
CPD units for the main convention. To earn the complete CPD units for the main convention, provide a per session or per day certificate and accomplish the post-test for the 4-day convention. Links for the CPD application and test will be posted on the website. Now let's begin.
Online etiquette and convention reminder.
Background noise. See that there's no disturbance like background noise or people moving around to avoid distractions. Sit in a good lighted and noise-free room.
Test equipment and internet speed. Check the laptop or desktop before joining the webinar. Choose a spot with an unlimited and strong internet connection. Use headphones or earphones to reduce the background noise.
Log in on time. Be on time. Join every session at least 10 minutes prior to the session. Value other people's time.
Mute your mic and camera off. Please put your microphone on mute and camera off during the session to avoid interruption of the presentation. Be polite, do not interrupt.
Leaving the session. Do not close or leave the Zoom app during the session to avoid being logged out that will result to incomplete attendance.
Asking questions. All questions will be entertained after the presentation. You may type your question on the chat box so that the moderator can take note of it. Keep your questions minimal and on the topic.
Be prepared for technical difficulties. In case of technical glitches, kindly send us a message through the email or social media outlets or through SMS.
Profile and display name. Choose a suitable profile picture. Name yourself formally the way you want to present yourself.
Certificate of Attendance. Certificate of attendance will be given only after the participant has accomplished the daily evaluation after the daily session. Links will be showed on the screen and on the CCNAPI website. Kindly wait for 7 to 14 working days to receive your certificate.
Self-directed learning application. Self-directed learning may be applied for those who cannot complete the 4 days main convention. An application form for the self-directed will be included with your daily certificate.
CPD units for the main convention. To earn the complete CPD units for the main convention, provide a per session or per day certificate and accomplish the post-test for the 4-day convention. Links for the CPD application and test will be posted on the website. Now let's begin.
Today, healthcare can enjoy the benefits of smarter devices that are more and more connected with the hospital environment. This evolution has allowed for improved patient care and better workflow for all medical professionals. That's why Fresenius Kabi has introduced the Agilia Connect line of Wi-Fi-enabled infusion pumps, along with the Vigilant software suite. So, the central nurse station, Nurse Mary can monitor her different patients using the Vigilant Sentinel software. She can follow the status of every pump in real time. And if an alarm is triggered on the pump, thanks to the Link Plus, she'll be immediately informed and able to react. At a single glance, she can easily see which infusions and patients require the greatest attention.
Dalex Pharma International is a Filipino-owned and managed pharmaceutical and medical device company with the aim to bring affordable and quality medicines in the ICU setting. Home of Dalex ICU Forum, a train-the-trainers program to raise the standard of critical care practices. Your prescription doesn't just save lives, but they transform lives to our CSR program. Care LGL and Dalex Pharma introduce NeutraClear, a completely transparent neutral displacement connector that prevents catheter-related bloodstream infections. Its exclusive design guarantees that best practices are followed and ensures patient safety. NeutraClear's smooth, flat septum makes it easy to disinfect. The guiding seal ring protects needleless connector's integrity. Its 2.8 cm size and 1 gram weight reinforces care comfort in neonatology and pediatrics. The neutral displacement design prevents blood reflux in the catheter. Thus reduces the risk of occlusions and infections in the catheter. Its completely transparent needleless connector ensures best hygiene practices and is recommended by experts for effective flushing. NeutraClear, the closed system which guarantees neutral displacement and complete transparency to prevent catheter-related bloodstream infections.
A wonderful day and welcome to everyone. Before we start our program, let us have a moment of silence for our prayer, followed by the national anthem and CCNAPI hymn.
Bayang magiliw, perlas ng silanganan, alab ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manlulupig, di ka pasisiin, sa dagat at bundok, sa simoy at sa langit mong bughaw. May dilagang tula at awit sa paglayang minamahal, ang kislap ng watawat mo'y tagumpay na nagniningning. Ang bituin at araw niya kailan pa may di magdidilim. Lupa ng araw ng walhatit pagsinta, buhay ay langit sa piling mo. Aming ligaya na pag may mga api, ang mamatay ng dahil sa'yo.
At CCNAPI, we care for a better world. This is our passion, beyond our profession, committed we'll ever be. To learning, training, we continue equipping, be the best that we can be. To care for humanity. draw strength from God Almighty. We care for patients to restore their optimal well-being and live a life of quality. See healing flow through the love we sow. With high touch, high tech at CCNAPI, we care for a better world. The world needs more people who care, and we are a people who dare. We give all we are, we give only our best. We are the Critical Care Nurses Association of the Philippines. We are CCNAPI. At CCNAPI, we care for a better world. This is our mission, our pledge to the nation. Committed we'll ever be to learning, training. We continue equipping, be the best that we can be to care for humanity. We draw strength from God Almighty, and through Him we set people free. From darkness we hold on to life and see healing flow through the love we grow. With high touch, high tech at CCNAPI, we care for a better world. With high touch, high tech at CCNAPI, we care for a better world.
Good morning, dear participants, distinguished guests, Board of Nursing, PNA President, speakers, and sponsors. Welcome to the 2021 CCNAPI Annual Convention with the theme We Rise, Resilient, Innovative, Solid, and Engaged. The impact of the pandemic has been hard to everyone, emotionally, financially, personally, and professionally. Despite the challenges that we face because of the pandemic, we believe that if we stay resilient, continuously adapt and innovate, stay solid, committed, and engaged, we can emerge stronger during these unprecedented times. We hope that this webinar can help us inspire more nurses. Now, let us hear a short message from the organizers.
The novel coronavirus 19 changed the world in an instant.
For over a year, COVID-19 has put all frontliners, specifically as nurses, in the most vulnerable yet challenging and noble position.
We are tasked and expected to hold the line and brave the tides as we push to rise against this generation's most difficult time.
We, the Critical Care Nurses Association of the Philippines, are committed to combat the invincible enemy.
And will continue to assure that we are one with the world in this battle.
We are gathered here today with one common objective:
to be reminded that we, the critical care nurses of the Philippines, are empowered with resilience,
molded with an innovative spirit,
indefatigable, solid, and relentlessly engaged.
We are humbled and grateful to bring this year's convention to each one of you in the comforts of your haven and ensure everyone's safety.
We welcome you to CCNAPI's first virtual convention.
Year 2020 made us use the phrase new normal.
From our personal daily grind to our fulfilling our professional obligations.
We appreciate technology and hinge on new protocols in making uncharted territories possible to explore.
This year, the CCNAPI's 2021 convention aims to share with you the intricacies of the COVID-19 critical care, from nursing practice response to patient safety.
Through our invited international speakers, we will have a glimpse of the world's perspective of critical care nursing during the pandemic.
The virus is complex and complicated. It places us at the middle of various difficult places.
However, hope is not far from the horizon. We will rise above this challenge.
The challenge may be wide and deep, but it can never doubt the spirit of a nurse giving critical care.
May this convention inspire you to continue embracing your resilient spirit, that you have the capacity to adapt and evolve through innovation.
You are not alone, and you are propelled to act boldly and solid with others.
And you are willfully engaged to make a difference amidst wrath to the pandemic.
This phase shall pass.
And we, the critical care nurses, are at the heart of this.
Together,
We will push forward.
Together,
We will overcome.
And together, we will rise.
Hello everyone, once again I'm Camille Pilak and with me is Mr. John Christian Agustin and we will be your moderators for today. The main goal of this 2021 annual convention is to provide the different characteristics of critical care nursing practice and nurses as they rise above the challenges of COVID-19 pandemic during this declared year of nurses. During the course of this 4-day event, our speakers will demonstrate enhancement of critical care nursing practice in adult, pediatric, and neonatal population who are with critical illness pathologies, discuss the different evidence-based practice guidelines on safety measures during COVID-19 virus pandemic, present measures that can prevent and alleviate potential patient safety issues in the ICU, discuss the different situations and COVID-19 response from different Southeast Asian countries, provide opportunity to understand and various global perspective of care, and interact with other nurses from around the world. To formally start the event, may we call on the overall chairman for this year's convention, Ms. Diana Jean SERONDO, to give us the opening remarks.
Thank you, Camille. Good morning. Welcome to the 2021 Annual CCNAPI Convention. It is an honor to speak with all of you today virtually. As much as we wanted to conduct this traditionally, however, we are bounded by the limits of our actions with safety as our number one priority. As we start CCNAPI's first ever virtual convention, I would like to take this opportunity to thank all of you, critical care nurses, for being such great frontliners in this era of global coronavirus pandemic. Congratulate yourselves as you are doing such a wonderful job. I would also to take this opportunity to acknowledge and thank you for gracing us with your presence today, to our dear Board of Nursing and distinguished special guests. I would like also to thank our convention partners and the organizing committee for making this virtual convention possible. And as a member of the organizing committee, we were inspired to create such a great and mind-blowing scientific program for you critical care nurses. With that, we built the convention around this year's theme, We Rise, resilient, innovative, solid, and engaged. And as we continue to live and adjust to a new and better normal, I hope that these plenaries and sessions will enrich your knowledge into becoming a new and better critical care nurses that continues to be resilient, innovative, solid, and engaged. In line with our innovations for this virtual convention, we have also prepared our website, that's www.ccnapi.org, to accommodate your virtual needs. Kindly visit our page to suit your needs. At this point, let us start this wonderful virtual convention, which calls each and every one of us to cross the bridge together, survive this pandemic, to take further steps to eliminate the pandemic, and together we rise. Thank you, and I hope you will have a very insightful virtual convention experience with us. To further commence our program, I would like to call our dear President, Maria Isabelita C. Rugado, for the introduction of the PNA President and the members of the Board of Nursing and to introduce our keynote speaker.
Good morning, ladies and gentlemen. The Critical Care Nurses Association of the Philippines, as a national nursing organization, has been supportive and will always be supportive of the professional nursing roadmap towards 2030. It is an honor and great pleasure to introduce to you the great nursing leaders of our profession, the PNA President and the members of the Board of Nursing, who will be giving us the messages or their messages for this 2021 annual convention. So let us all welcome them and hear their messages.
Good morning. A pleasant day to all of you who are present in this virtual convention of the Critical Care Nurses Association of the Philippines. To our dear nurses, kamusta po kayo? I am attending an online mass of the Divine Word when Ma'am Bel Rugado sent me a message for this greeting, and I remember Father Jerry Orbos describing our struggles of the previous year as if we are wandering in a desert. Indeed, a very challenging 2020 to all of us, full of fears, anxiety, uncertainties, and difficulties that we do not know when will it end. Nobody knows. But struggles are part of life. Kaya naman nurses, stay strong and let us all be reminded that God will not desert us, especially when we are in the desert. Allow me to thank Ma'am Bel Rugado for giving me the opportunity to be part of your convention. And on behalf of the Philippine Nurses Association, we congratulate you, the officers of CCNAPI, and the organizers for coming up with this activity and for having a timely topic or theme, which is We Rise, Resilience, Innovation, Solid, and Engaged. Resiliency is the key to conquer challenges in life. Just like the saying goes, tough times never last, but tough people do. Tough times never last, but tough nurses do. This reminds us that we should always bounce back. Basta ang importante that we should keep in mind that it is not all about bouncing back. Kasi pag bounce lang ng bounce, para lang tayong bola. The important thing is the process. That during the process, we should learn, grow, and become better. Innovations and keeping engaged are part of resiliency, as well as being solid or being strong. Think positive that all ends well. All will be well soon because God loves us. Things will get better. It may be stormy now, but it never rains forever. So nurses, keep going. We can do this. Let us put an effort to win or succeed after being close to defeat or failure. We will rise as one. Once again, congratulations CCNAPI and have a great day to all of you. Enjoy this convention at mabuhay po tayong lahat.
Hello everyone. Every time I get an invitation from the CCNAPI, I always relate it to this symbol of the human heart. As we all know, this is the heart consisting of 4 chambers: the right and the left atrium, the right and the left ventricle. Why am I saying this? Because if you are going to visualize and cut the heart of this CCNAPI leadership, the organizing committee, as well as its members, what you can see in the chambers of the heart will be the bubbling evidence of diligence, commitment, as well as dedication in pursuit to their mission vision. As I remember throughout the years, when I attend the CCNAPI conference, I always see the leadership of President Bel Rogado and its officers with dynamism, full of energy. And this can be shown by their 5-day conference, which they have slated for this annual conference. I can see the progress of this association. It's because of the commitment being offered by its officers and members of the association. I'd like to say, continue on with the good job. You are doing an excellent job. And I hope that your work in partnership with PRC Board of Nursing in terms of your career progression will soon be materialized. Thank you for inviting us. Go on. Despite this pandemic, I can see that there will be success in what you're doing now as an association. Magandang umaga po sa inyong lahat.
Congratulations to the 2021 Critical Care Nurses Association of the Philippines Incorporated organizers, members, officers, and participants. My deep appreciation to the very active President, Dr. Isabel B. Rogado, and my prayers for a successful convention with your theme for nurses, R.I.S.E, to be resilient, innovative, strong, and engaged in this pandemic times. Congratulations.
Let me start by saying congratulations to the organizer of this 5-day convention with a theme for nurses to rise, to be resilient, innovative, and engaged in this pandemic time. Same felicitation goes to the 2021 CCNAPI officers headed by Dr. Isabel Rogado and ably assisted by the rest of the officers and members. Indeed, the theme fully describes how nurses excels in these global difficulties, showing professionalism, fortitude, and readiness related to our job. The hard work, dedication, and perseverance of our nurses are one of the examples of bravery and endurances, dedicating their hours in saving lives. Thank you all for being on the front line to help and care for people who are in great need. Again, congratulations to all the dynamic officers and members of the Critical Care Nurses Association of the Philippines Incorporated.
Good morning to everyone. Nurses experience enormous challenge, burden, and uncertainties of preserving lives amid this time of pandemic. Critical care nurses rises and proves to be more resilient, innovative, strong, and engaged to provide quality and safe care to clients and their families at these fragile times. This is Bon Zeni Concepcion Gagno, extending my warm and heartfelt greetings to all officers, organizers, and members of Critical Care Nurses Association of the Philippines Incorporated for your 2021 annual convention. May God protect you and your families. Stay safe, healthy, and enjoy your annual convention. Mabuhay kayong lahat. Maraming salamat.
My warmest congratulations to the officers and members of the Critical Care Nurses Association of the Philippines Incorporated, CCNAPI, on the occasion of your 2021 annual virtual convention. Your theme for this year's convention, We Rise, bespeaks clearly of the organization's timely and relevant response to the emergency health crisis brought about by the COVID-19 pandemic. Together as one, you did not allow CCNAPI to succumb to the threats and challenges of COVID-19 pandemic. Instead, you made it rise above the very challenging and uncertain situation. Through your resilience and innovativeness, you continued the mission of CCNAPI to serve with no boundaries. Through your strong, solid support by your active and engaged membership to the organization, you made CCNAPI a very strong and relevant organization today. To all of you, once again, my warmest congratulations, especially to the organizers and officers of CCNAPI, headed by the hardworking and dynamic President Bel Rogado and her equally dynamic and hardworking team members. Mabuhay kayong lahat. Mabuhay ang CCNAPI. God bless you all and good luck for the next 5 days of your convention.
I greet all the board of directors of the CCNAPI, as well as the entire membership of the organization for the holding of the 2021 CCNAPI Annual Convention. The theme of the convention couldn't be more appropriate than apt, and this is exactly what critical nurse professionals, actually not just critical nurses, but all nurse professionals, all professionals even, actually everyone in the globe, needs to do to adapt the present challenges and face our reality head on. As your theme says, we need to be resilient, we need to innovate, we need to be strong and to be engaged. As we all rise triumphant in battling and ending this pandemic, as we all rise as one triumphant nursing community, as we all rise together as one nation, as one globe.
So again, it is my pleasure to introduce our keynote speaker. Today, we are fortunate to have with us a very dynamic, committed nursing leader who has been a consistent honor student and a nurse who has risen from the rank as a bedside nurse, clinical instructor, professional reviewer for nursing and midwifery, a professor, a dean, and currently the nursing program coordinator of the Graduate School of San Pedro College in Davao City. As a theorist, she has numerous publication and research works that are focused on education. As a dynamic leader, she was an ARQUAT assessor for nursing in various nursing institutions and EQUAMI assessor for the Commission on Higher Education. Her involvement in various nursing organization has made an imprint on her commitment and engagement for the improvement of the nursing profession. Ladies and gentlemen, it is my honor to present to you our keynote speaker, the nurse numero uno in the Philippines, the PRC Board of Nursing Chair, Dr. ELSEE Timbresa Antiporta T. Let us all give her a warm welcome. Thank you very much.
Video, please. Can I have a video? Okay, can you hear me? Can I be heard?
Yes,
Yes, ma'am.
Okay. Madam Maria Isabelita C. Rogado, President of CCNAPI, or the Critical Care Nurses Association of the Philippines. Ms. Diana Jean F. Serondo, Overall Chair of the Organizing Committee. The honorable members of the Professional Regulatory Board of Nursing, the officers and members of CCNAPI, esteemed guests, nurses, a pleasant morning. At the outset, in behalf of the Professional Regulatory Board of Nursing, I would like to congratulate the officers, organizers, and members of CCNAPI for this celebration of their annual convention and scientific meeting with its theme, We Rise, Resilient, Innovative, Solid, and Engaged. It is noteworthy that despite the pandemic, you still managed to host this large convention. And that is a clear manifestation of your resilience as an organization and a very positive reflection of a strong leadership. Resilience, by definition, is the ability to bounce back and not break in the face of adversity. Resilience is a quality we nurses must possess because of the stressful nature of the nursing profession. Resilient people are said to have physical, mental, emotional, and psychological strength. Resilience is often ascribed as a factor that can mitigate against stress, and the person or organization who has it would successfully adapt in the face of stress and adversity to recover from these difficulties and to potentially gain strength from them. We all face adversity every day, although we view situations differently. What is adverse to one may not be to the other. Resilience is very critical, especially that the nursing profession is being threatened by staff shortages during this time of the COVID-19 pandemic. Nurses have succumbed to the tension brought about by stress and are leaving or resigning from their jobs. This, we know, is currently happening in various institutions across our country. Thus, building resilience from within the nursing profession is vital to safeguarding its future by keeping newly qualified nurses in the job and by preventing emotional burnout across the discipline. It is also a known fact that nurses are leaving the profession early in their career, often due to the immense pressures that they work under. Workplace stress, exacerbated by staffage shortfalls, is likely to be playing a major role. Research provides evidence that working conditions are a major factor in nurses leaving the profession. In short, there is a multitude of stressors in nursing practice, ranging from emotional labor, of the need to be compassionate, work overload, and a lack of resources like PPE, which especially during these times matter a real lot. Research reveals that the NHS in UK is short of thousands of nurses, with those leaving the workforce citing a range of reasons, including pay cuts, low morale, understaffing, and poor work-life balance. Could resilience help nurses weather some of these or all of these? Studies have shown that those who have high levels of resilience are less likely to develop stress disorders and more likely to remain in the profession as healthy nurses. This is one reason why some think tanks think resilience should be taught in schools. How then do we promote resilience? There are key strategies to promote resilience according to Davis in 2020, and it includes building self-esteem by reminding yourself of your strengths and qualities, trying to replace negative thoughts about a problem with positive ones. Another is maintaining a supportive social network of nursing colleagues. Talk to them about problems and make use of your combined experiences. Resilient individuals usually have a good social network and they ask for help when needed. Talking to a support person can lead to finding different solutions to a problem, but at times it can just be connection to compassionate others, which can be comforting. Trying to be flexible as possible in the face of change is one key strategy. Sudden changes, in particular, can seem very disruptive. A can-do attitude, therefore, helps you to see problems clearly and act appropriately. Then there is the self-care. Nursing is a demanding profession, and it is vital that you care for yourself as well as care for your patients. Taking time for self-care is an important part of resilience because it allows us to recover. Then, taking action to solve problems as soon as they are encountered. The longer you leave it, the more stressed you will feel. Setting reasonable goals to deal with problems is another one. Break problem solving down into small, manageable steps. Experiment with and use a range of problem solving strategies. Above all, remember that many problems that nurses face in their daily work are the result of organizational weaknesses or failures. Try not to feel responsible for situations that are beyond your control. Next in the acronym R.I.S.E is the letter I, standing for innovation. Innovation means to improve or to replace something in a process, a product, or a service. Others would describe it as a process by which a domain, a product, or a service is renewed and brought up to date by applying new processes, introducing new techniques, or establishing new ideas to create new value. In simple terms, it is an idea that has been transformed into practical reality. Very simply, it is the introduction of something new. Nursing is a very dynamic profession. It is always changing, updating, and improvement. And as health information is churned, nursing changes. And nursing must change because innovative activities improve health outcomes. Also, as new machines are invented, nursing changes and nursing processes change. We know that rapid technologic development is driving improvements in healthcare to provide better patient outcomes, create more meaningful patient engagement, and offer virtual capabilities for clinical services, like, for example, telemedicine. Innovations are about improvement in quality, cost, effectiveness, or efficiency, and nurses are critically positioned to provide creative and innovative solutions that make a real difference to the day-to-day lives of our patients, organizations, communities, and profession. This is according to the International Council of Nurses in 2009. Without innovation, there will be no progress. And if an organization is not making any progress, then it cannot stay relevant in the market. Case in point is a cell phone company. Most, most of us know this mobile phone brand. I just wouldn't want to say its name. In 1998, it overtook Motorola to become the world's largest mobile phone brand. And its pinnacle in 2007, it got 51% of the global market share in mobile phones. But it sold to Microsoft in 2013, almost in bankruptcy. What were the company's mistakes? There are 4 key mistakes accordingly. 1, they focused only on hardware so that when this cell phone falls, it does not break. Second, there is a reluctance to change the operating system to Android. It stuck to Windows Phone, which is now discontinued. Third, it has become a dysfunctional organization. It changed from the standard hierarchical organization to the matrix system in the hope of increasing innovation. But with a new structure, many managers had equal authority, which inevitably led to power struggles. At that time, Apple was led by the laser sharp, not razor sharp, Steve Jobs. And the fourth reason is they missed the smartphone wave. Lesson learned: innovation is crucial to the continuing success of the organization. Let me share with you the story of an eagle whose experiences can be likened to the changes that an organization must undergo in order to continue to exist and stay relevant. It is said that the eagle has the longest lifespan of its species. It can live up to nearly 70 years. But to reach this age, the eagle must make a tough choice. Because when the eagle enters its 40th year, its long and flexible talons or claws can no longer grab prey, leaving the eagle hungry most of the time. Also, its long and sharp beak starts to bend. Then its old or aged and heavy wing stick to its chest, making it difficult for the eagle to fly. At this point, the eagle has 2 choices: die or bear a painful process and change. Should the eagle choose pain? This is what she does over the next 150 days. The eagle first flies to a mountaintop. It then starts knocking its beak against a rock until it plucks out and waits for its beak to grow back. Once the new beak forms, the eagle starts to pluck out its talons. When the new talons grow back, the eagle starts plucking out its feathers. This painful process lasts 150 days. After which, the eagle takes its famous flight of rebirth and lives for 30 more years. This is from www.mydost.com. And what are the lessons learned? One is change we all must. And the second is to know and accept that change can be a painful process. We have nurse innovations which are crucial to the pandemic today. So, today, it may be hard to see the innovation in nursing on an industry-wide level, but some of the most important changes in healthcare today are pioneered or implemented first by nurses. One is the American Red Cross. The idea started from nurse Clara Barton, who experienced firsthand benefits of the Red Cross in Geneva, Switzerland. At that time, the mission of the Red Cross was care for the sick and wounded by war. Barton brought it to the United States and founded the American Red Cross in 1881. Clara Barton's selfless efforts to establish an organization equipped to help others in need demonstrates what it means to be a nurse. Then we have patient positioning for transport and intensive care. In 1926, Elizabeth Kenny, an Australian nurse who cared for patients during World War I, began work on a trauma transport stretcher. Seeing how challenging it was to transport patients in emergency situations, Kenny designed a versatile stretcher. There are straps and pads and cushions for all emergencies, and the completed stretcher may be adjusted so that the patient may sit up, lie down, or travel in whichever way is most comfortable. Another feature is that if an operation is necessary, the patient need not be moved. The stretcher may be used as an operating table. Today, stretchers are a staple piece of equipment found among our first responders, emergency departments, and intensive care areas. Then we have, in addition to transport, body positioning in a hospital bed. During COVID-19 pandemic, patients with the virus who develop acute respiratory distress syndrome may be positioned prone to improve ventilation. Proning is a challenging position for patients in critical condition, and nurse Kathleen Volman in her time saw the opportunity to solve this problem by inventing the Volman prone positioner in the late 1980s. Her patented invention was the foundation of subsequent inventions to help support the safe and consistent prone positioning of patients in ARDS, which is a solution to help with proning during this COVID-19 pandemic. Fourth is clinical simulation, another nurse innovation. As nursing students' clinical rotations came to a halt during COVID-19, nursing schools across the US, including our country and the rest of the world, turned to innovative clinical simulation strategies and activities to support students' learning needs. Clinical simulation dates back in 1910 yet, when A. Lauder Sutherland, a nurse in charge of Hartford Clinical Hospital Training School in Connecticut, invented the first simulation mannequin. Sutherland got tired of the makeshift straw-filled dummies her nurses had been using, so she worked with Martha Chase, a Rhode Island doll maker, on a more realistic mannequin. The training doll she made became known as Mrs. Chase, and we have that in school, no? Since that time, the science and art of clinical simulation has significantly advanced and grown to be quite sophisticated, thereby enhancing nursing students' practical skills and knowledge. What is the role of our nursing leaders? The Innovation Roadmap, a guide for nurse leaders, recommends that nurse leaders embrace the following characteristics to promote a culture of innovation. Encourage and value divergent thinking, support and manage risk-taking behavior, be willing to tolerate and learn from failure, embrace agility and flexibility in designing solutions, and promote autonomy and freedom to instill confidence in employees' abilities and decision. To achieve a culture transformation that embraces innovation, leaders must be ready for the challenge, exploring opportunities, nurturing creativity, and ultimately transforming care. The S in R.I.S.E stands for strong or solid. In order for an organization to be resilient, its leader needs to be strong. Organizations generally look for a leader who will act with integrity, can adapt to changes, and have a diverse set of skills. This leader provides direction for the company and at the same time, innovative ideas and solutions from others. They share lessons learned to promote better practice. Last but not least, this leader strengthens relationship and fosters collaboration and cooperation. There are 4 keys to building a solid organization. One is the formulation of a vision. That is a clear, comprehensive photograph of an organization at some point in the future. This provides direction because it describes what the organization needs to be like to be successful within the future. Another is to lay a strong foundation. Strong organizations are built in the same fashion as tall buildings. One must go deep digging the foundation before it can possibly go high. One must dig in and get real about the purpose and scope of the organization. Third is work smart. A good organization is built by people who have made it their business to learn all they can build it as solidly as possible. People who think ahead and plan for all possible scenarios. And the fourth is form a great team. Building a building or an organization for that matter designed to last a lifetime takes a massive team effort. There is no greater value to an organization than a dedicated team. So, accordingly, there are 3 enabling conditions for the team today. 4D team, they call it diverse, dispersed, digital, and dynamic. So we have a compelling direction. So this is set by the leader. You have a strong structure, which is composed of the high-performing teams to include members with a balance of skills. Diversity in knowledge, views, and perspectives, as well as in age, gender, and race, can help teams to be more creative and avoid groupthink. Third is supportive context. This includes maintaining a reward system that reinforces good performance. The last letter in R.I.S.E stands for engaged. Since we are nurses, the question therefore is, what is nurse engagement? Nurse engagement refers to a persistent, positive state of fulfillment experienced by nurses at work. When nurses are engaged, they feel energetic and dedicated to their work. They become immersed in work activities. Engagement has also often been described as the opposite of burnout. Some strategies for improving nursing engagement include genuinely acknowledging the significance and complexity of the work provided by the nurses. Providing support, leaders must create a positive practice environment where employees feel valued and supported. Provision of training is a kind of support valued by staff. Another is respect for people. Nursing is a tough job, physically, mentally, and emotionally. If nurses are not respected, they are likely to feel undervalued and unsupported. This can have an impact on their engagement and motivation levels. Another is to communicate your ethics and core values. Communication of core values need to be intentional. If your organization's values are to provide the best quality health care, communicate it. Remind people of their contribution and purpose regularly. That way, people will feel a sense of pride in their work and feel more motivated to deliver on their goals. Then, leaders must lead by example. They need to bring passion and energy to their roles if they want nurses to follow suit. To achieve higher engagement within the team, leaders need to create and constantly drive an environment where people can do their best and receive timely feedback. Then we have to introduce rewards. Aside from thanking people for their contribution in day-to-day feedback, formal rewards programs can ensure individuals are being celebrated regularly. This could include spontaneous rewards like movie or dinner vouchers and gift cards, or formal processes with open nominations and a selection committee. Some healthcare organizations have introduced regular awards, including Employee of the Month, Nurse Excellence, and this one I like, Zero Harm Awards. 10, encourage health and well-being. In a profession where around-the-clock care means long shifts are required, healthy habits can be forgotten or put aside. Organizations can help by offering subsidized gym membership, yoga, and Pilates classes. Snacking is another area where health and well-being can be encouraged. Snacks with fresh fruit options should be offered in hospital cafes and canteens. And lastly, we have to get the support of senior leaders. Leaders who are motivated to improve the culture are most likely to clearly communicate organizational behavior, organizational vision, and desired behavior. The concept of nurse engagement is often used to describe nurses' commitment to and satisfaction with their jobs. In reality, these are just two facets of engagement. Additional considerations include nurses' level of commitment to the organization that employs them, and also their commitment to the nursing profession itself. Because nurse engagement correlates directly with critical safety, quality, and patient experience outcomes, understanding the current state of nurse engagement and its drivers must be a strategic initiative. That is, in a capsule, we rise, resilient, innovative, solid, and engaged. If nurses, including their organizations, can be all for, then happy all, as they say, in the organization. And patients will not only experience patient satisfaction, but instead patient delight. In closing, may I leave this quote by D. Hock. An organization, no matter how well designed, is only as good as the people who live and work in it. Good morning and mabuhay kayong lahat.
Thank you so much, Honorable Chair ELSEE, for that very inspiring message.
Welcome po.
Our next speaker is presently a nurse trainer that specializes in stroke, neuroscience, and neurocritical care nursing, and currently the board secretary of the CCNAPI. She is a board-certified neurovascular registered nurse and a stroke-certified registered nurse. She has been a stroke nurse, section manager, and stroke coordinator at St. Luke's Medical Center Global City Stroke Service from 2008 to 2017. She also became the stroke care program specialist for Angels Initiative program Born Here Philippines, a member of the Critical Care Society, American Association of Neuroscience Nurses, Philippine Neurocritical Care Society, and Stroke Society of the Philippines. One of her latest major achievements was being selected by the Neurocritical Care Society as an International Nurses Leader for the Year of the Nurse last July 2020, a certified Lean Six Sigma Yellow Belt and CDA-T, to pay tribute to the legacy of the late Mrs. Nolly V. Pagdanganan and give us an update on the 2020 Philippine Nursing Roadmap. Let us welcome once again Ms. Diana Jean Serondo.
Thank you, Camille. So to start our updates on the 2020 Philippine Nursing Roadmap update. These updates objectives will have us revisit the 2030 Philippine Roadmap framework, review the roadmap initiatives involvement of CCNAPI, and provide the update on these initiatives. The Philippine Nursing Profession Roadmap has 14 initiatives, and 4 of these are the focus of the CCNAPI. CCNAPI's initiative is among these 4, which is to live the core values and to manifest the desired qualities of a Filipino nurse, involving the definitions of what a Filipino critical care nurse should be. The second and third would be to enforce the quality standards in education and nursing service, and to institutionalize sustainable organizational support structure for nursing career progression, which is geared towards the attainment of service excellence. And lastly, to address competency enhancement is to institutionalize a sustainable and effective continuing professional education. First, in order to define the desired qualities of the Filipino nurse, such as the critical care nurses, there are 10 or 11 rather parameters that should support these qualities. I would like to highlight a few, which is in the field of study. The academic requirement for a critical care nurse is to have a postgraduate education in acute and critical care nursing, which is designed to have more than 9 weeks or 360 hours to didactic training and at least 120 to 200 hours of clinical training. Now, the critical care nurses education program shall have an accreditation approval from PRC or Commission on Higher Education or wherever is applicable. The professional setting is defined as the hyperacute and acute care settings whose clients are diagnosed with life-threatening conditions or who are being intensively monitored to prevent serious complications. This setting is limited but is qualified but not limited to having intensive care of either adult, pediatrics, or neonatal. As a minimum work experience for the critical care nurses, it is required that an individual should have rendered at least 6 months of generalist practice. In this track, a clinical nurse 1 or even a clinical nurse 2 have different minimum work experience classification and recommendation. As an entry-level nurse, CCNAPI recommends a 6 months transitioning program from a generalist practice to an extended role in critical care nursing specializations. And a higher level as a clinical nurse too, CCNAPI recommends a minimum of 3 years continuous critical care experience that should be fulfilled. As a mandate for personal and professional development, CCNAPI recommends that professionals will earn CPD units to be able to update and renew their certification. The focus of the nursing practice standards of the specialty organization will revolve the individual's responsibilities in care provider as a direct patient care or indirect patient care, and having extended roles of critical care nurses, which could be an educator and as well as a patient advocate. A critical care nurse can have a specialized area as critical care nurses or with subspecialization in either a complex and multidisciplinary team involvement to either the critical care team, resuscitation team, rapid response team such as acute brain attack team, or emergency neurological life support. And of course, to have a creative and innovativeness and social responsibility involvement to their responsibilities in any institutions, as well as leadership and governance and involvement in research. As critical care nurses, we should apply the research process in improving the patient care, infusing concepts of quality improvement and in partnership with other team players. Next is to gear on the service excellence is to enforce the quality standards in education and nursing service. The service excellence envisions that the education and practice should explicitly define the standards of practice that is aligned with the nursing practice and promulgated by the PRC Board of Nursing. CCNAPI made the recommendation for these 13 practice standards, and this can be fully viewed, which is fully viewed and downloaded as part of our downloadable materials on our website. So you can visit our website at www.org under News and Events to download a copy of the Professional Qualification Framework and Standards of Critical Care Nursing Practice. Next on the service excellence would be to institutionalize the sustainable organizational support structure for nursing career progression. So this is all about the National Nursing Career Progression Framework. So in here, the PQF has three levels, which is the level 6 for the baccalaureate program, level 7 for the post-baccalaureate program or the master's program, and the level 8 for doctoral education program. And we have three nursing tracks here, which is involved on the nursing service track and the clinical practice track and the academic track as well. So just last November 2020, the CCNAPI recommendation for PQF level 7 and 8 were accepted by the PRC bond. So here as a level 6 or entry level nurse, you can start as a general practice nurse, and then later you can you can become a specialty nurse and then become a nursing specialty in the critical care area. So when you become a specialty nurse, you can advance to level 7, which is an advanced practice nurse, but you are required to complete your master's degree program. Next on the item would be the alignment matrix between the critical care nursing qualification. So the PQF is described by the following descriptors in terms of knowledge, skills, and values, the application, and its degree of independence. So under knowledge, skills, and values, we have to demonstrate advanced knowledge and skills in specialized or multidisciplinary field of study. In the application, we are required to be in the professional or creative work or even research that requires self-direction and or leadership in a specialized or multidisciplinary professional. And a degree of independence should be substantial that involves exercise of leadership and individual initiative. So in terms of professional practice outcomes, the critical care nurse advanced practice outcomes were stated according to the practice standards framework of the PR bond that include the 4 standards of practice, which are the values-based nursing practice, knowledge-driven nursing practice, outcome-oriented interpersonal relationship, and leadership and governance. So this can be viewed in this framework, which is to ensure that all 4 will lead to the care for family, critically ill patient clients, and community. So these 4 standards can be viewed as the 4 standard domains. So this would be the values-based nursing practice, which involves clinical decision-making process, evidence-based nursing practice, which we have to involve the consensus, explicit, and judicious use of the current best evidence in making decisions about the care for individual patients. Next is with the outcome-oriented professional relationship, which is the result of the intra and interprofessional relationship that could lead to the enhancement of one role in critical care nursing. And lastly, on the leadership and governance. So here we have the advanced practice nurses. So it is our pleasure to inform all of you that the advanced practice nursing is already a part of the comprehensive bill that is now in Congress. So this is the House Bill 741, which is an act providing comprehensive nursing law towards a quality healthcare system. So here, they have defined advanced practice nurse is a nurse who has substantial or higher level of theoretical knowledge and decision-making skills in specialty area, and as well as the specialized and expanded role of APN is stipulated in this board resolution. It is also differentiated with that of a specialty practice nursing, which is referring to the practice of a nurse in a specialty area for which the nurse needs to obtain specialty recognition after having undergone a specialty training. So these nurses are referred to as specialists, and they have this minimum qualifications. as well as the APN is also being stipulated further as the direct, autonomous, or collaborative expert care of nurses with a higher level competencies as defined in this act. And as stated earlier, these have an expanded competencies over and above the general practice nurse requirements, and the minimum qualifications are as follows. The APN has also the following responsibilities in collaboration with and under the terms of specified collaborative agreement with a collaborating physician. And here are the 9 recommendations for that. So the fourth one, or the last one, is about the commitment or addressing the competency enhancement, which is to institutionalize a sustainable and effective continuing professional education and development for individual nurses and institutions. So this covers the education for nurses for critical care specializations, which could be part in these 4 items. It could be under the orientation program, preceptorship, or even mentoring program. Can be in service training program, or can be obtained in a continuing professional education. And of course, can be undertaken by certification course, such as the critical care nursing program. So in conclusion, these initiatives are just some of the highlights of how 2020 unfolded in the Philippine nursing profession and its nurses. The hard work and dedication of nursing leaders has blossomed, and we are now harvesting its fruits. As the nursing profession was awarded by the following citations from the Professional Regulatory Board, which are rather, as being the Outstanding Board of Nursing, which is the PR Board of Nursing, the Outstanding Profession, which is the Philippine Nurses Association, and the Outstanding Professional, who is none other than Dr. Sheila Bonito. With that, let's travel together the road to excellence, and together we rise. Thank you and have a good morning.
Thank you, Ms. SERONDO, for the updates on the Philippine Nursing Roadmap. Our first plenary will cover the nursing consideration in fluid navigation in the ICU. The learning outcomes for this plenary is to provide value-based care in safe, effective, and efficient manner for the sedated patients and at risk for delirium. This plenary is sponsored by Pfizer. We are delighted to introduce the next speaker. Our speaker is an alumni of the University of the Philippines College of Medicine, Manila, where he also earned his postgraduate degree. He took his internal medicine residency training at the UP-PGH and had his fellowship training at the Medical City for Adult Critical Care Medicine. He is currently the head of the intensive care at the Asian Hospital and Medical Center. He is also a part-time lecturer at the University of the Immaculate Conception College of Pharmacy and Chemistry. Ladies and gentlemen, let us all welcome Dr. Aaron Mark Hernandez.
Thank you very much for the privilege to speak to you today. So, first, let me share my slides. So, good day. Thank you very much again for allowing us to discuss this important topic. So, it's nursing considerations in fluid navigation in the ICU. Just a disclaimer. Here are the objectives for the discussion today. So to define fluid stewardship, to navigate through the fluid therapy model, to describe the 4 Ds of fluid therapy, and to discuss the roles of ICU nurses in fluid management. So let's kick off with a case. We have JDC, a 68-year-old male who's 63 kilograms, admitted for shortness of breath at your ER. The patient has a history of ischemic heart disease treated by undergoing coronary artery bypass grafting 5 years ago. The patient has a good functional capacity prior to this ER admission. The patient has been unwell for 3 days with productive cough, increased sleeping time, and fever. At your ER, the following vital signs were noted. On physical examination, you noted that the patient was drowsy but arousable, had cold, clammy extremities, minimal urine output was noted after Foley catheter insertion. So the questions that come into mind in this case are the following. First and foremost, is your patient in shock? If we are the ones to respond to the patient first, what will be your initial management? So we have a set of choices here. Among the strategies that we want to discuss here is to answer the question, will we be giving fluids? So choose one of the following letters here and type it in the chat box. This will be our point of discussion for the whole session. So I will not give the answer yet. You'll get the answers later during the run of the discussion. So you have A, B, C, D, or E as your choices for giving fluids. I'll give you a few seconds. Okay, everybody done? So I will proceed with the next. So some facts. Facts meaning fluid administration in critical illness groups. So what do we know or what should we know about fluids in general? So intravenous fluids are the most commonly administered drugs in the critical care unit or for critical care adults. So IV fluids are drugs. Again, they are drugs. Meaning, as drugs, they have their own indications, contraindications, benefits, risks, adverse effects, and complications. Actually, fluid and electrolyte disturbances are the most frequently reported problems in the intensive care unit, with inappropriate use of fluids occurring in around 20% of patients and over 20% of ICU patients receiving some form of intravenous resuscitation at some point during their admission. More than 30% receiving fluid resuscitation during the first day or the first 24 hours when they are admitted in the ICU. And virtually all hospitalized patients receive some form of intravenous fluid therapy to maintain volume status or hydration and as diluents of the different drugs that are being administered. So why are fluids given? On your screens are the reasons gathered in a survey done in 2007 and 2017 for administering fluids. Along with the major indications are the prescribers of the fluids. Though the majority of the prescribers are physicians, nurses also contribute to fluid resuscitation measures, as you see in this slide. Since we're talking about indications, the next few slides I will just run to you the existing guidelines for critically ill patients which have discussions on fluid management. So just as a primer for the next few slides, a recommendation is stronger than a suggestion. So what we want or what is best practice are the recommendations, and those that we may consider are suggestions. So first, we discussed the Surviving Sepsis Guidelines of 2016. This is still the latest from the Surviving Sepsis Campaign group. We see the recommendations include administration of at least 30 ml per kilogram of a crystalloid for the first 3 hours, and the use of frequent reassessment of hemodynamics, preferably using dynamic parameters, to check if more fluids are to be given. The recommended goal is a MAP of 65 for septic shock, patients needing a vasopressor, while it is suggested that we do a lactate targeted resuscitation for our septic patients. Going further into the guidelines, other recommendations include the use of fluid challenge guided by hemodynamic monitoring if more fluids are given. In terms of the fluid choices, crystalloids are the fluid of choice, with these guidelines not giving a formal recommendation on which type of crystalloid to use. There is a suggestion that albumin may also be beneficial if the clinician sees that a significant volume of crystalloid would be needed for resuscitation, while hydroxyethyl starches are a big no-no. Now going back to our shores, I'm presenting to you part of the Philippine sepsis guidelines, to which I had the opportunity and privilege to be part of the technical working group. Some of the recommendations actually agree with the surviving sepsis guidelines that I have previously mentioned. However, the Philippine guidelines lower the strength of some of the recommendations, including the initial resuscitation volume, to just a suggestion instead of an actual recommendation, which alludes to the rest of the discussion on fluids. So you will see later on why the recommendation changed from an actual recommend to a suggest. So we'll see most of the recommendations from the surviving sepsis guidelines are similar to that of the Philippine sepsis guidelines, except the strength of initial resuscitation. Further, the Philippine sepsis guidelines suggest a limit to the amount of resuscitation fluid that can be given in the first 24 hours to 5 liters. Should there be a need for more fluid, guidance should be sought targets and the uses of indices of fluid responsiveness. So what to use to assess for fluid responsiveness? The guidelines suggest dynamic variables and recommend the use of non-invasive cardiac output monitoring strategies using the point-of-care bedside ultrasound and the passive leg raise techniques. The guidelines explicitly recommend against the use of actual CVP or central venous pressure values to assess for fluid responsiveness. So actual values. Trends may or it can be used as one of the monitoring parameters mentioned above, but actually using the CVP number per se is not recommended. Relating to the limits, to limiting the fluids given for sepsis patients, the guidelines recommend active deresuscitation by preventing positive cumulative balance. After a review of literature showed that positive balance after day 3 of sepsis is associated with worse outcomes. All in all, the local guidelines recommend an individualized approach to the integration of various modalities and maneuvers to assess for fluid responsiveness. So from the two guidelines, we are in a tug of war between pushing more fluids versus limiting fluids, which is actually now the trending question in critical care. Before, it was just to push fluids to prevent hypoperfusion and to ensure adequate circulatory volume. Now, studies have come out warning everybody of the problem of fluid overload and its consequences on outcomes. Each concept Both hypoperfusion and fluid overload is a problem of its own, both leading to poor outcomes. You will see here in the slide that under resuscitation or hypoperfusion and fluid overload have their own adverse effects, which both lead to poor outcomes. It is up to the clinicians to do a balancing act in balancing the right amount of fluids for your patients. Fluid administration goes back to the pathophysiology of shock and septic shock specifically. It is not just hypovolemia, which is the problem. And basing on these diagrams, a little too much or a little too or too little of fluids may worsen the shock state. The need to reach this state of fluid balance that we have been going through for the past slides in terms of how much is given is further described by the rule of force for fluid therapy, which has been discussed by the International Fluid Academy. The rule of four states 4 questions, 4 indications for fluids, the 4 Ds of fluid therapy, and the 4 stages of the fluid therapy model. Whenever management of fluids comes into picture, a clinician has to attempt to answer the 4 questions shown here, which deal with starting or stopping giving fluids and starting or stopping fluid removal. To answer the questions and also to discuss the one of the other sets of the 4s, we have to know where our patient is in terms of the R.I.S.E model of fluid therapy. So the 4 letters of R.I.S.E. Professor Malbrain and colleagues presented the fluid therapy model R.I.S.E, which is a continuum of different phases with volume status, plotted against time. It starts from the resuscitation or the rescue phase, which is this one, which concentrates on life-saving measures by providing early, adequate fluid management, followed by the optimization phase here, which is where we focus on organ rescue with conscious avoidance of fluid overload. After optimization comes stabilization here. Focusing on organ support and rate conservative fluid management. And letter E, the one here, then stands for evacuation, which focuses on organ recovery with management strategies aiming to resolve fluid overload from the avoidance to actual active removal of fluid. Of course, taking into consideration that hypoperfusion or too much fluids is removed. So taking into consideration that hypoperfusion does not happen. Apologies for the rather busy slide, but this just summarizes that each of the stage has its own cause, has their own indications of fluid, the recommended fluid dose, the target fluid balance that we want, and the impact of giving fluids, making us determine what goal of fluid therapy for the phase is. So here, one will see the questions initially posted a while ago, as well as some questions that can further help the clinicians gauge the need for giving fluids. So you will see in this table that resuscitation is usually the resuscitation model or resuscitation phase has inflammatory insult as its background cause, while optimization phase has ischemia and reperfusion as the background cause, as well as stabilization, while evacuation has global increased permeability syndrome as its primary problem and hypoperfusion late into the evacuation phase. In terms of the time frame, the resuscitation phase happens within actually seconds to minutes into the shock state. Optimization happens around a few hours into the ICU management, while stabilization happens within days and evacuation from days to weeks. So this dilemma situation and the growing concern for fluid overload adversely affecting our outcomes has led to the conceptualization of the quality improvement process called fluid stewardship. This is a term coined by the members of the International Fluid Academy. It formalizes and treats fluids as drugs and aims to optimize clinical outcomes while putting adverse effects to a minimum. This strategy resembles that of what everyone is familiar with, antimicrobial stewardship, which takes into consideration the right drug, early detection of fluid-related adverse events, and containment of costs, ensuring that fluid therapy is cost-effective. So the process of intravenous fluid treatment is divided into 4 stages based on an audit framework developed by the NICE group or the National Institute for Health and Healthcare Excellence. So like the review of medications recommended by the American Society of Hospital Pharmacists, an IV fluid prescription must be audited using the following parameters, or the IV fluid therapy must be audited using this. So in an audit, you assess the fluid therapy need. Is it for resuscitation? Is it for maintenance, for replacement, or for redistribution? Of course, the fluid therapy order should have a clear prescription, which follows the complete medication order as prescribed by your institution. Intravenous fluid prescription should follow quality standards, which adhere to the hospital, to local, and international standards and guidelines. And of course, IV fluid prescriptions will be judged according to the appropriateness, how appropriate the process was, and how appropriate the prescription was. Going deeper into the quality standards and discussing the next set of 4s in the rule of 4s for fluid therapy, here are the 4 Ds of fluid therapy. This is a mnemonic that goes through the prescribing. This is a mnemonic that goes through considerations the clinicians have to run through when prescribing fluids. At the same time, these 4 Ds serve as a key performance indicator or serve as key performance indicators that can be monitored to assess the quality of fluid care delivery the clinicians are providing to the patient. So the 4 Ds are drug, dose, duration, and de-escalation. This is just an illustrative summary of how the 4 Ds of fluid therapy correspond to the 4 Ds of antimicrobial therapy, another management concern wherein too much use leads to worse outcomes, leading to antimicrobial resistance. We will go through each D one by one. First D is the drug. When considering the drug, we consider the type and class of the drug, of the fluid, its content, the route of delivery, and the chemical properties of the fluid. Why are these important? For instance, a fluid type with very high osmolality can easily destroy peripheral veins. So this fluid type needs a central venous access for administration. Another, in terms of tonicity, we do not want to give hypotonic solutions as volume expansion fluids, especially to neurologic patients, wherein use of hypotonic solutions run the risk of further worsening cerebral edema. The other factors in terms of medication for the drug, we also have to consider the clinical factors that may make us shy away from using this type of fluid, like the renal function, and again, as mentioned above, the presence or absence of cerebral edema. So when monitoring drug interventions, the fluid is assessed for appropriateness of therapy, the possibility of combination therapy, which can be considered for maintenance fluids while you are giving nutritional intake, or the consideration that you also need to use or you may have to use albumin or albumin-based fluid administration in resuscitation. And we assess appropriateness of timing of fluid administration, which is related to the fluid therapy model that has been discussed in the previous slides. Since we are in the discussion of the appropriate drug/fluid to use, we end up with a question which has been posted for almost a century. So this century-old question: what is the ideal fluid? So how do we choose what fluid to give? Here on your screens is a rundown of some of the more commonly used crystalloids and colloids and their content. As mentioned, it is important to be familiar, but not necessarily memorize, the important chemical characteristics of your IV fluid, along with the tonicity and osmolality that we have discussed in the previous slide. We want a fluid that is near plasma in terms of content, and that fluid should not adversely alter strong ion differences and should not affect the overall ion or electrolyte equilibrium. That discussion of getting what we want for an IV fluid is and always has been a floating want. So what is the ideal resuscitation fluid? It produces a predictable and sustained increase in intravascular volume. As mentioned, it has a chemical composition that is as close as possible to that of plasma or extracellular fluid. It should be completely metabolized and should not have any form of tissue accumulation. You do not want a resuscitation fluid that causes adverse metabolic and systemic effects. And of course, it should be as cheap as possible. It should not, it should be cost effective in terms of improving patient outcomes. Unfortunately, at present, no such fluid is still available for clinical use. So what are we left with? What can we use? There have been a number of studies. Actually, there have been plenty of studies on fluids for resuscitation. So to help us decide in terms of the fluid choice, Cheng and colleagues published a systematic review and sequential network meta-analysis just this December of 2020, studying the different fluid types in different critical care states. So we just concentrate for sepsis in this discussion. So here are the results. Just to guide everyone, this is a surface under the cumulative ranking curve area, or SUCRA. In this reporting tool, the higher the bar or the higher the value, the better. So let's go to interpreting the table or the graph. So interpreting the SUCRA for mortality, as shown here, mortality, balanced crystalloids appear to be the best option. Saline and the two types of hydroxyethyl starches, which is LH and HH in this graph, are not favored. The SUCRA also shows that the colloid use, so the use of the colloid, was associated with lesser resuscitation volume than crystalloids. The highlights here compared saline and isoncotic albumin. The SUCRA ranking also revealed that gelatin, balanced crystalloids, saline, and isoncotic albumin had a much lower risk of acute kidney injury than both types of hydroxyethyl starches. And the SUCRA revealed that crystalloids and isoncotic albumin were associated with lowering the need for transfusions or decreasing the transfusion volume compared to colloid use. In summary, it appears that the balanced crystalloids are more favored as resuscitation fluid in spite of the higher fluid volume that needs to be infused to get the clinical effect. Isoncotic albumin may also be used. So it's albumin that is diluted in a crystalloid. Of course, there are cost considerations given that albumin is a bit expensive. So we move now to the dose. Here, we go to the translation of drug dosing studies to fluid dosing studies. We deal with volume kinetics, volume dynamics, and volume toxicology. Yes, it really looks like pharmacology altogether. Kinetics deals with how the body affects the fluids, with concepts like volume of distribution, as well as half-life of the fluid coming into the picture. In essence, changes that happen to the fluid from its administration to its distribution to the rest of the body, to its metabolism, and ultimately to its excretion. On the other hand, dynamics deals with the dose-response effects, knowing the dose of the fluid needed to reach the desired effect. For fluids, this essentially translates to the Frank starting curve, which will be discussed in the next slides. So here, determining the right amount of fluid or preload to make you achieve the desired cardiac output. So that is dose and response. Considering in this assessment, you have to consider the clinical background or the setting of the patient when you are assessing. Like for patients with ARDS, we know that we cannot give too much fluids as there is a risk of pulmonary edema, which can worsen the oxygenation status. Last item for dose is toxicology. This deals with the knowing of the drug slash fluid can cause toxicities. Meaning, we have to be familiar if your drug can cause a certain toxicity or increase the risk for a major adverse event, like hydroxyethyl starches, which have been studied to increase the risk of acute kidney injury and also increase the need for renal replacement therapy. So that translates to toxicology as either the effective dose for 50% of the population or the lethal dose affecting 50% of the population. We will not go to that discussion anymore. Just important to remember is when we discuss toxicology for fluids, it's related to the risks that the fluid give when you administer them. So going to the actual doses for fluids, here is just a summary table to show those recommendations for the different interventions during the specific phases of the fluid therapy cycle. Shown here, during the rescue or the resuscitation phase, the recommendation is a fluid bolus of 3 to 4 ml per kilo to be given over 10 to 15 minutes with repetitions as needed to achieve the goal of correction of shock, while making sure that perfusion is supported with a vasopressor when necessary. You can see here as part of the table the recommendation of 30 ml per kilo being a question. Why? Because the one-size-fits-all recommendation may be too much or still too little in terms of the actual fluid volume needed for some patients during the resuscitation phase. We can more accurately predict fluid need by using the volume responsiveness parameters and see whether the patient is still volume responsive. The concept of goal-directed therapy has been under heat for the past years, especially with the results of the protocolized or usual care sepsis management studies like the R.I.S.E, the PROCESS, and the PROMISE trials, which showed that the protocolized or usual care therapies were not inferior to early goal-directed therapy, and e.g. DT did not actually reduce mortality compared to these protocolized strategies. Frequent fluid boluses with corresponding fluid responsiveness assessments are really needed. In the rescue phase, actually, a positive fluid balance is acceptable. The fluid challenge, on the other hand, which you see more in the optimization phase, is defined as an administration of around 100 to 200 ml of a crystalloid over 5 to 10 minutes with frequent assessment and reassessment of hemodynamic status, meaning you assess the hemodynamic status before giving the fluid and you assess the status changes after the challenge. This allows the clinician to now construct a personalized Frank starting curve, helping in reaching a decision to give more or to set a limit when to stop giving fluids. The last two phases describe either the dose as to relate to actual fluid balance, meaning in the stabilization phase, you just have to make sure your target is around 0 to negative net fluid balance with the aim to ensure a balance of water and electrolytes to replace ongoing losses and provide organ support. And the evacuation phase, this comes in, when this comes in, you think of stopping the fluid altogether or actively removing the fluids either by ultrafiltration processes or administration of a diuretic. So the question of do I need to give more fluids, as mentioned for the fluid dose, you see here the Frank starting curve. When we are discussing dose response for fluids, we examine where the patient falls in this curve. Is the patient at the point where he or she is volume responsive? Or are we at the point that giving fluids will not further change hemodynamics? Beside the Frank starting curve in this slide, is an algorithm lifted from the Philippine sepsis guidelines as to how to assess and manage fluid administration during resuscitation. There are numerous techniques that can be performed to assess fluid responsiveness, all with the goal of determining whether we are this part. We are in the steep portion of the Frank starting curve where the patient is most fluid responsive, or are we here? This flat part, the flat part. So meaning you want a significant response, which is the steep part, and we want this part. We don't want this part technically. When we reach this part, we're just saying that stop, or maybe at this point, which is the plateau or flat portion, additional fluids might not change cardiac output significantly. So that is the dose response curve, or the Frank starting curve for fluids. Here, a number of techniques and measures have been discovered to check for fluid responsiveness. These measures have been compared to standard cardiac output monitoring and put into consideration the complex heart-lung interactions in interpretation. They range from the most non-invasive to the use of mechanical ventilation techniques and invasive catheters. As a recommendation from numerous guidelines, frequent assessment of fluid responsiveness using dynamic measures of fluid responsiveness are essential to determining the right patient and the right dose. Along with the list shown here are the cutoff values or the thresholds, as well as the pros and the cons of the different methods. From these, we can predict that when a parameter, is above the cutoff, we may give fluids. So it will be beneficial for the patient that we give fluids if we're above it. But below, fluids may not be beneficial anymore. This again emphasizes that fluid management or resuscitation should not be the cause of delay in vasopressor administration, as you can also continue fluid assessment while giving the vasopressor. So it means that if your patient is at the is below the threshold, don't hesitate to start a vasopressor early. Then continue fluid assessments as needed while on pressor. So we have the dose and the drug. To close the discussion on these two, here is a simple mnemonic, on the administration of fluids considering the dose and the drug. This is troll. Hindi yung trolls, this is not the troll that we are problematic in social media. It's troll. So troll describes the type of fluid, the rate, or the dose to give, the reason or the objective for giving the fluid, and the limits or when you stop giving the fluid. These are also what you look for in the fluid prescription. After the first two Ds, we go to the duration. Important to the duration of fluid therapy is determining where we are in the fluid therapy model, with each phase happening more or less within more defined periods of time, from minutes to hours for rescue and optimization, to days for stabilization, and days up to weeks for evacuation. Remember that the longer the delay in fluid administration, the more microcirculatory hypoperfusion and subsequent organ damage related to ischemia reperfusion injury happens. So we have to manage the patients as fast as we could. The graph below shows the results of 3 studies showing that the best survival comes from early conservative, late conservative fluid management, with early and late as defined here in the slide, followed by early adequate, which is a more liberal strategy, plus late conservative, which is EALC here. And this graph shows you that going for a more liberal fluid state, especially late in the ball game, places more harm than good for our patients. After duration is the escalation. The escalation is knowing when to stop giving the fluid. At the same time, the escalation is also representative of the term deresuscitation, which goes beyond the actual stopping, because the resuscitation is the actual removal or the active removal of excess fluid. Just some points in the escalation. This advocates late go-directed fluid removal. And there are steps to remember when you are dealing with the escalation and the resuscitation. You have to define a clinical endpoint. You have to set a fluid balance goal. Set safety limits. This is what is mentioned here as set perfusion and renal safety precautions. Make sure that the safety limits are evaluated as often as possible, and adjustments in the plan are changed according to the re-evaluations. So now that we have gone through the concepts of fluid stewardship in general, how do critical care nurses join the campaign in supporting stewardship or fluid stewardship? This is a study conducted among critical care nurses in Australia and New Zealand. The respondents are categorized according to their educational background, the work pattern, meaning the shifting, the area or location of practice, the most common fluid type or the most common choice for fluid bolus therapy, and who usually decides when you administer the fluid bolus. In the first table, you will see that regardless of the area, the ICU registrar or the junior consultant or the junior intensive care specialist is the one who gives majority of the decision or the prescription for the fluid bolus therapy. However, as you will see in the figure here, according to the respondents, which here is 294 nurses, almost 50, half, to all the time, the critical care nurses initiated the discussion and the recommendation to the registrar about starting IV fluid bolus therapy to the patients, as again shown here. Here, majority of the time, the nurses are the ones who initiate the conversation. If you look at the data on the first table again, this big table, 18 of the respondents here can already prescribe fluids. They are the ones who gave the prescription. This means that there are already institutions, maybe not here, outside the Philippines or internationally, that are where critical care nurses are allowed to decide and prescribe fluid bolus therapy in the ICU when absolutely necessary. With proper training, skills, and acquiring knowledge as well, in which the last table shows here the respondents' knowledge and attitudes in terms of fluid bolus therapy. The nurses can be able to be partners or actually prescribe fluids. As a steward in fluid therapy, we want to increase these numbers from 18 more. We want to raise more of the 18 here to empower the critical care nurses in contributing and collaborating with physicians in initiating fluid bolus therapy in the ICU. Maybe we could start with just increasing this part of the figure. We want maybe to place everyone here in the figure wherein discussions for fluid therapy are between the nurses and the physicians half or almost all of the time. As for this lecture, this is a start of giving you the knowledge and understanding how fluid management is and application in our actual practice. Aside from prescribing or initiating fluid therapy, these are the other main roles of nurses. So you will see here in another study in South Africa. Ensuring adequate fluid balance by maintaining or properly administering fluid therapy prescriptions and documentations are necessary. So you will see here, there is a problem of inadequate fluid calculation and monitoring. So it is important that fluid balance monitoring is accurate because interventions to follow rely on this. There are factors which may affect inaccuracy of fluid calculation in which the nurses have an important role to play. Documentation on the following variables may have an impact on the fluid balance monitoring in our critically ill patients. So this is an example of nursing standards being developed for maintaining fluid and electrolyte balance in the ICU. This is a study conducted in Egypt by critical care nurses to ensure that practices and competencies go hand in hand. So you will see here that there is a competency questionnaire which was made and actually comparing the competencies to the actual practice. This slide will show you the expert's opinion on what actually should be the nurse's basic competencies in fluid management. From measuring the CVP or measuring basic hemodynamics to measuring the INO, daily weight changes, to the actual physical examination and monitoring of lab tests and ECGs. Translating, so when the researchers actually compare this list of competencies to how they are being done in clinical practice. So there are strengths and weaknesses in terms of the competencies when translated to actual practice. So we know which processes need to be given more attention and need more more enhancement in terms of fluid management. Like for example here, weighing the patient daily as part of fluid management was not done in all 40 situations that were checked. This may be a problem also in the Philippines since most of the beds in the ICUs are not weighing beds. However, it is important that the nurses know and everybody in the healthcare team also are familiar that weight is also a measure of the fluid status of patients since per liter of weight translates to a kilogram actually of weight gain. So, so these are the parameters here, some good points and some points that need to be further worked on to enhance nursing skills in fluid management. So the role of the nurses in initial resuscitation, of course, vary in terms of the clinical area where they are in, with the critical care nurses being more involved in the actual hemodynamic monitoring since they are more expert in the invasive and non-invasive strategies for fluid and volume assessments. So the critical nurses, the critical nursing community also has set some guidelines that they think should be part of the quality improvement initiatives to make sure that the sepsis guidelines are optimally followed. To highlight, the nurse's role in initial resuscitation does not end when the medical staff arrives at the scene. So it does not end when the code team comes and the doctors start ordering. Successful resuscitation depends on the collaborative integration of the skills and expertise of all members of the rapid response and the multidisciplinary team. It is not a one-man show. So fluid management and critical illness. In the end, as I go towards the end of this lecture, why is it critical to know? So for effective fluid stewardship to happen, there should be doctor and nurse ambassadors. There should be comprehensive fluid bundles and organ function monitoring programs. And these are to control the adverse or deleterious effects of inappropriate fluid prescription and fluid overload. And overall, to reduce costs. So this is just a summary of what we saw a while ago into a very nice infographic. So translating it into actual memory practice. I know most of you are familiar with fast hugs, with some actually familiar with the extension of fast hugs being fast hugs BID. So the original fast hugs is feeding, analgesia, sedation, thromboembolic prophylaxis, head of bed elevation, ulcer prophylaxis, glycemic control, spontaneous bleeding trial, bowel regimen, in the monitoring for the indwelling catheter removal, and the escalation of antibiotics. So these are the fast hugs BID which has been made by critical care nurses from the ESICM and the SCCM. Some critical care pharmacists in the US actually have recommended to add another F. So it's F2, it's fast hugs, double F, with fluids coming into the picture as part of the essential bundle to be monitored. So just a short summary, during fluid administration, always evaluate and check for its appropriateness. Through a collaborative team approach, assessment of the patient, an indication for fluid therapy, appropriateness of IV fluid choice, management and monitoring, we are able to practice optimal fluid stewardship. Regardless of the situation navigating through the fluid therapy model or navigating through fluid therapy in the ICU. Fluid therapy is part of the overall management and care of our critically ill patients. It's part of what we do. Each team has a vital role in providing the best care for the patients, fluid or not fluid in terms of management. And just as one of the slogans from an ICU in Alberta, Canada, great teams result to provision of great care. So thank you very much and stay safe to everyone. Good day.
When you want to save humans from disease, ask science. It will make the breakthrough because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win.
When life is at stake and time is running short, when every second counts and every moment counts, choose the one that is strongly recommended as the first choice vasopressor. Norepinephrine, Levophed SF, restores blood pressure in certain acute hypotensive states. In life-saving situations, choose norepinephrine, Levophed SF.
Thank you so much, Dr. Fernandez, for that informative lecture. Thank you, Pfizer, for sponsoring the plenary. To all participants, kindly send your questions for Dr. Fernandez via Q&A section, and questions will be answered or entertained during the live Q&A after all the sessions. Thank you. For our next discussion, we will center on the early warning score. The lecturer will provide us with the evidence-based tool that we can utilize when providing rapid response for patients who are at risk of deterioration. This session is sponsored by IDS Med. Our next speaker is Dr. Robert BILKOVSKI. He has earned his degree as a Doctor of Medicine from Rosalind Franklin University, the Chicago Medical School. He completed his residency training for emergency medicine at the Henry Ford Hospital in Detroit, Michigan, and graduated with a master's in business administration from the University of Notre Dame. He has more than 10 years of combined clinical and industry experience in the pharmaceutical and medical device industry, including in vitro diagnostics. He assumed medical leadership roles for several Fortune 500 companies, including GE Healthcare, Abbott Laboratories, and Becton Dickinson and Hospira, to name a few. Currently, he is the president and the founder of the R&D Ventures Consulting Incorporated. His area of clinical expertise are in emergency medicine, anesthesia, pain, critical care, infectious disease, fetal medicine, and cardiovascular medicine. Let us all give a warm welcome to Dr. Robert BILKOVSKI.
Hi, this is Dr. Robert BILKOVSKI, and I am very honored to have the opportunity to present at the CCNAPI annual convention. The topic of this presentation is early warning scores, and I hope you find this presentation to be informative and helpful to your clinical practice. First, a little bit about me. I'm a emergency medicine trained physician that practiced for 10 to 15 years with a fair amount of emphasis in the fields of critical care and sepsis and non-invasive technologies. In the past 10, 15 years, I've developed expertise in industry, primarily in pharmaceuticals, medical device, as well as in vitro diagnostics. I am the founder and president of R&B Ventures Consulting, and I am a consultant and receive consulting fees for work with GE Healthcare. Otherwise, I do not have any financial interest in any commercial entities, specifically stock ownerships, advisory boards, or the like. So this is the agenda for our presentation today. We will provide an overview on early warning scores and their importance. What is NEWS, which is an acronym? Compare and contrast NEWS versus NEWS 2. Provide some clinical evidence to bolster the argument of how these early warning scores can improve clinical care. And then lastly, tie it off with some practical considerations, getting an understanding of how to implement this within the acute care environment. So first, let's talk about the early warning scores and why are they important. So first off, critical illness requires timely recognition and timely intervention to reduce morbidity and mortality. No different than patients that have acute myocardial infarction, the door to EKG, the door to needle time. All of those things are important because time is money. Very similarly in stroke as well as in say sepsis, where a need to standardize the approach of care and recognition is important. As an example, in the field of sepsis, early goal-directed therapy attempted to do that. Quite biased because I trained at Henry Ford Hospital where early goal-directed therapy came. I think it was very instructive in shaping clinical care around timely recognition and timely interventions in patients that are at risk of having sepsis. There are some challenges. People in the medical community have challenged the robustness of what is called the SIRS criteria, and there's been some migration towards a score called the Q-SOFA score. The specifics around Q-SOFA are outside the scope of this presentation, but I will touch base on it later when I'm going over some of the clinical research that has been published. Tying it into the United Kingdom, where this where the NEWS was first founded, the Royal College of Physicians back in 2012 stated that early detection, timeliness, and competency of clinical response are an important triad to be able to determine clinical outcomes in patients with acute illness. And there have been numerous reports at the national level focusing on these acute care environments having what's called a track and trigger system that is the nidus of an early warning score, primarily to be able to go and efficiently identify patients at risk and then being able to standardize care delivery to them to reduce the risk, hence the introduction of NEWS. So let's go into a little bit of detail on the topic of NEWS. Like I said, it was founded in the United Kingdom and it was deployed across the hospitals of the NHS back in 2012. And like I said, it was the goal was to standardize the assessment of patients with acute illness, identify those that patients at risk of clinical deterioration, initiate timely and competent clinical response. And then identify what patients require higher or lower intensities of monitoring, as well as higher or lower intensities of ongoing care, such as a ward, step-down unit, or an intensive care unit. The physiologic parameters are quite straightforward. We're familiar with them. They're part and parcel of vital signs, but they're listed here. You have respiratory rate, oxygen saturation, the systolic blood pressure, level of consciousness, as well as temperature. And of note, new onset confusion was added, and I'll mention that briefly in a few slides. In 2018, the news score was revised into what's called the News 2 score. And the following slide, albeit busy with graphics, I just wanted to focus on two things. The News 2 score, which is on the right, provided some additional granularity on what is called the SpO2 scale 2, which reflects a grading for patients that are hypercapnic, such as those that have chronic COPD, where their SpO2 normals may be less than 91. In addition, they added a caveat for new onset confusion, whether that is a patient that was normally maintaining and now is delirious and or confused. That generates a score of 3. But simply what you see is that you have these graded columns going from normal outwards to higher scores, and the score is cumulative. So identify as the parameter and cross-link it to whichever score it gets, tally them up, and therefore you obtain the news or the News 2 score. And the purpose of the News score is to be able to standardize care at thresholds. So typically 2 thresholds are meaningful. A score of 5 or greater is a key clinical threshold for higher risk. The Royal College of Physicians has even touted that patients should be alerted and concerned for sepsis at this level. And then any patient that has a single red score also hits a critical threshold for escalating intervention response and interventions. So let's focus on the clinical evidence that's associated with News and News 2. First, a large study that was done by Lee, looking at over 10,000 patients, and were eventually able to evaluate 1,300 patients that stayed in a hospital for greater than 72 hours, and simply looked at the News score and being able to predict in-hospital mortality. And the hazard ratios for medium and high risk were quite profound and statistically significant. The hazard ratio for medium was 2.6, or almost 3x greater than the normal than a normal population, and in high risk it was 4.7, or almost 5 times greater than the normal population. Moving on to a slide from Melamar that was looking to compare and contrast the News 2 compared to the Q-SOFA score in patients with sepsis and organ dysfunction in a emergency department setting. Now remember, the Q-SOFA score has been recently touted to be a more robust measure for identifying patients at risk for sepsis. The News 2 score here actually shows that it has greater benefits being able to identify this at-risk population. And I take your attention to the gold shaded box in the top left, looking at News 2 versus Q-SOFA scores in the variable, the area under the curve. The AUC is a measure where the closer to 1 that you approach, the better it is. And it is a balance between the sensitivities and specificities to identify the optimal cut point of the performance of one diagnostic measure versus the other. The Q-SOFA score scores at 0.71, which is strong, but clearly not as good as 0.80. And these scores were statistically significant. So this study helps to illustrate that the News 2 score may actually, in fact, be better than the Q-SOFA score in being able to identify this patient population, specifically detecting sepsis and organ dysfunction from the emergency department. Moving on to a subset of a patient population that comes into the emergency department, and that would be the frail elderly. So those 70, 80 years of age, lower body weights. We in the United States look at patients on pounds, but say 120, 140 pounds, or 50, maybe 60 kilograms. Where their body mass and their risk for any type of unwanted infection or illness could be quite damaging and in this study, patients with higher NEWS2 scores were seen to have a statistically significant increased risk for 30-day mortality. And they were actually able to separate or dichotomize NEWS2 score based upon green groups, yellow groups, red groups based upon the NEWS2 score strata. And there's meaningful breaks that if you obtain a score in the quote unquote red group, your mortality rate was 23.2%, almost 1 in 4. Yellow group is still at high risk at 7.6. And it's important to understand, even if you score green, this is a pretty delicate patient population. So mortality for these patients as they present into a hospital is not trivial and still remains relatively high at 4.1%. But it's important to identify that the NEWS2 score helps to stratify the prioritization of the patients that are at the highest risk to be able to mitigate against any morbidity and mortality to that population. And then lastly, and I think more importantly, given the times since 2020 with the onset of COVID-19, is how does the NEWS2 score show its effect in a population that's infected with COVID? And interestingly enough, this study, which was quite nicely done by Merstad, was comparing the NEWS2 score of a normal cutoff of 5, a cutoff of 6, the historic SIRS criteria of 2 or more, and then the most contemporary sepsis criteria of Q-SOFA scores. And if I shift your attention to the blue box, the area under the curve for the NEWS2 score greater than 6 was your most robust at 0.822. The NEWS2 score of 5 was also strong and robust at 0.786, but the NEWS2 score of 6 actually broke in favor of being the more meaningful predictive score for patients that are infected with COVID-19 and at risk for in-hospital mortality. So now changing gears into the more clinical and practical implications. And want to share some insights. I'm an ER physician, so I will apply an ER-centric view of this. But typically patients come into triage, they are assessed by a nursing team, and they make assessments of the prioritization of when to be seen, where to be seen, and the intensity of services. This is a perfect opportunity where the NEWS2 score can help the triage methodology to prioritize being seen and allocation within the emergency department. Once they're in the emergency department, you can apply the patient onto a patient monitor. Patient monitor technology now has embedded early warning scores or NEWS2 scores capabilities. And the NEWS2 score alarming mechanisms can be used to further stratify patients while they're being cared for in the emergency department to help to identify those that need additional care, additional interventions, or change discharge dispositions from the emergency department, whether that's to the floor or to the intensive care unit. Let me share a graphical display of a sample output. On the left would be a typical patient monitor, and what you're seeing on the right are the various inputs that inform the early warning score. The early warning score is illustrated in the bottom box, orange box, with a number of 11. Clearly, that is abnormal. If you go into that patient monitor's details, it will be able to go and provide the output on the right that identifies the values that have resulted in the NEWS2 score scoring at 11. So clearly here we can see that the score of 3 of SpO2 is a problem. The patient is on supplemental oxygen. The pulse rate is quite high, and confusion is present. Let me change gears and let me make it a little bit more tangible and provide a simulated patient example to further illustrate the opportunities where NEWS2 score can be beneficial. So take a 60-year-old male who comes in complaining of feeling weak and has a cough. multiple different conditions can be from upper respiratory infections to influenza to coronavirus to pneumonia to sepsis. The vital signs at triage are listed here, and the News 2 score is a value of 3. And the patient was placed on a cardiac monitor. The patient was seen and was getting a chest x-ray. And then 2 hours later into their care, you can see the vital signs to the right. And if you look between each variable from temperature, respiratory rate, and heart rate, the numbers don't change that much. There's subtle changes. However, the News 2 score is drastically different. It's 7 now. I took the liberty of illustrating some of these differences and where they're flagging some differences here. And of note, the chest x-ray came back. The patient has a left lower lobe pneumonia. The concern for sepsis has been rightfully raised. A lactate was obtained, and the lactate is quite abnormal at 4.4. This patient originally was being touted as being appropriate for admission to the general medical floor, but now with the patient's News 2 score of 7 and elevated lactate, the patient's disposition was changed to intermediate care or an IMU, where the patient still receives intravenous fluids, intravenous antibiotics, and close monitoring of oxygen saturation levels will be done in the IMU environment. And hopefully that helps to paint the illustration of a real world clinical example that could be seen tomorrow, the next day that you are seeing patients. And in closing, just like to encapsulate that we went over early warning scores, the basis of why they're important, and what was the purpose of news being deployed within the United Kingdom, and how News 2 score was changed in 2008. What were the 2 key variables that were added? And then most importantly, showing some research and real world clinical evidence that identifies how the news score and or the News 2 score can inform patient risk. And then more importantly, and contemporaneously now with COVID-19, as how it can be supportive in risk stratifying your COVID-19 infected patients. And on that note, I will conclude this presentation. And once again, thank you for your time and your attention on this. Have a great day.
Thank you, Dr. Robert, for that very informative lecture. It gave us a better picture on how early warning scores work and how does it make an impact in the current healthcare setting. So good day, everyone. My name is JC Agustin, and I am your co-moderator of the day. So we are about to proceed to the question and answer activity. So can I call back Dr. Aaron Hernandez to answer some questions related to his topic, fluid navigation in ICU. Also, I would like to inform everyone that Dr. Robert will not be able to attend this activity, but feel free to type in your questions. We will send it to the representative of IDS to forward it to Dr. Robert and then email it back to you. Is Dr. Robert around? Hi, Doc.
Hello JC.
How are you, Doc?
Okay naman.
Okay.
Hello everybody. Good morning. Morning pa. So, I answered two of the questions already sa Q&A box, but I chose to leave the other one to be answered live kasi I think I need the help of the nurses in trying to convince people regarding this eh. So the question is actually very relevant eh. The question is regarding the use of plain NSS versus plain LR in fluids shock states.
Yes,
So
Doc.
the question is, dalawang beses na mention eh. Is it true that NSS has a lower pH than LR and prolonged fluid resuscitation with this may cause acidosis? So why is it common practice to use NSS versus LR? So to answer the first question, yes, it is true that plain NSS is more acidic than plain LR. And plain NSS causes hyperchloremic metabolic acidosis. And prolonged resuscitation can really cause acidosis. Actually, there are studies, head-on studies that actually compare plain NSS with all other crystalloids. And the results show that most of the delays in response come in when you give more than 2 liters of plain NSS in fluid resuscitation. Now, the second question is very important kasi nga plain LR is more balanced than plain NSS. But why are we using, mas maganda kasi yung first eh. Itatanggalin ko yung P because it is NSS is known as NSS because it is known as normal saline solution. So the misnomer is because it's normal and it's readily available, siya yung una mong gagamitin. However, there are actually journals that actually say that NSS is anything but normal. With us, actually, there's a journal titled AB, naka-parenthesis, that was normal saline. So essentially, our saline solution at present is not normal because it has supranormal sodium and chlorine contents. 154 mx per liter yon. So imagine, I made a lecture before during my training stating that about 2 liters of plain NSS will be equivalent to mga 4 to 5 boxes of pizza by slide. So imagine your kidneys, what will happen to your kidneys if you give too much of saline. The LR, the worry kasi with LR is there are some who are worried with the 4 mx per liter of potassium that is in LR. So, but remember, 4 mx is very small if it will change, if you are worrying of changes in equilibrium sa potassium. So, it may increase it to normal, but it might be not be enough to change the overall milieu of potassium in your body. So siguro being the ones who are with the doctors and the ones actually initiating fluid resuscitation, it would be a it has very great impact if during the recommendation for fluid resuscitation, the nurses can actually recommend that a balanced crystalloid, more or less plain LR at least, be given. Kasi actually sa ICU, sa hospital where I'm in, There are instances that the nurses actually say, baka gusto nyo po may LR naman po tayo dito, LR ang i-start natin. So it is really better than NSS in terms of fluid resuscitation, especially if you are to cross the border of 2 liters. Thank you.
Thank you, Doc, for that detailed answer. So while waiting for some questions, we'd just like to answer some of the participants' questions with regards to the pre-test and post-test link. For the pre-test, we don't have pre-test. Okay? So, ano yun? Regalo namin sa inyo. But for the post-test, we will have a post-test link on the last day. Okay? What else? Doc, what is the effect of too much saline in septic shock treatment?
So, too much saline in septic shock treatment, for one, it may worsen the acidosis that is usually present when you have refractory septic shock. The second thing is too much saline in the milieu delays. It gives a delayed picture that the patient is responding to your fluids, because by giving plain NSS compared to a more balanced solution, your response in terms of urine output, in terms of hemodynamic improvement, in terms of actual decrease in pressure requirement are lower than or slower than that of using a balanced crystalloid. So meaning, instead of, for example, as a illustrative example, instead of expecting that the patient will have some form of improvement in urine output after an hour of crystalloid, if you give plain NSS, that 1 hour might be 2 hours to 4 hours. That is actually according to one of the studies around 20, it's around 2000, less than 2000, around 2010. And so it gives, yes, it's a good crystalloid. Actually, in another critically ill state like that of trauma, plain NSS is still the recommendation, because of because there are no actual studies that actually compared plain NSS and balanced crystalloids, but it is changing. But in terms of septic shock patients, giving more saline places the patient at greater risk for the adverse effects of acidosis, both in your general management. So you will notice that patients will have slower responses to norepinephrine, to your usual therapies. So those are the general considerations when you think of NSS. So it has those effects in septic shock. I'm seeing other questions after.
Yes, Doc. Next question, Doc. What about the isotonic electrolyte solution like the sterofundin? What's their role in fluid resuscitation?
To be honest, sterofundin is um, one of those fluids that are starting to come out in multiple studies. Sterofundin is also a balanced solution. The problem with sterofundin is, one, it has calcium acetate as its buffer. So calcium accumulation is one of the problems with sterofundin if you are to give it as a bolus. So actually in recommendations, sterofundin, I haven't seen a recommendation that sterofundin is being given as part of the bolus. But if you want to maintain a more balanced or a more alkaline milieu after resuscitation, there are some who actually recommend sterofundin. But sterofundin has recommendations not in septic shock. It's more of trauma. In trauma and in surgery, in surgical critical care, sterofundin is one of their mainstays. So you just have to make sure that calciums do not shoot up. At the same time, sterofundin is also notorious in causing severe metabolic alkalosis. So in severe metabolic alkalosis, because it has an acetate as its buffer, and it is easily convertible to basic solutions. It causes drastic changes in pH to the point that it makes blood more alkalotic. But if your patient is relatively acidotic, it's of value. There.
Thank you, Doc, for that answer. I think we can accommodate up to two more questions.
Okay.
So, aside from your ultrasound and echogram, what other non-invasive techniques to be used to measure fluid responsiveness in settings with no available mentioned test?
Okay. That's a very nice question.
Mm.
So, for non-invasive techniques, what is usually recommended in at bedside is really the passive leg raise. So, this is from lectures by John Louis Van Sant and John Louis Tebol. If you use the passive leg raise, if you are in a setting wherein there's no ultrasound, no echo, or you don't have an invasive catheter in place, what you can do is actually set a number. You check you check for example your BP or your heart rate. If your value or the limit that you set, if you place a safety limit and you place a target, your target should be usually, for example, for heart rate, if the patient is tachycardic, your heart rate should at least lower by 10 to 20 points. That is your set limit after your leg raise. So if it does not work, remember the leg raise you can't do the leg raise repeatedly at the same time kasi you need some point wherein fluid has to accumulate in your lower extremities kasi your lower extremities usually contain around 300 to 500 of fluid. So it's relatively your fluid bolus or the fluid challenge. You're just doing it using the legs by raising the legs passively, raising the legs. So you use a safety limit. So on the other side, if the heart usually kasi what they use is yes, I mentioned CVP is not recommended anymore. But for example, you have CVP. For example, the experts actually mentioned that you place a safety limit. If you're worried that you want to know using the CVP if your BP, if your patient is responding, for example, your number is 20. Yeah, so it's a very high CVP. However, you have no choice but because the CVP is the only number that you have other than heart rate BP. So you use the CVP as your basis for the passive leg raise. If your CVP increases by 5 to 7, I will stop giving the fluid after the leg raise. But if the CVP does not increase, so 20, still 20, 20, 21, 22, but it does not reach the 5 to 7, I will still be able to give fluid. I know that the patient might be fluid responsive. So remember, for the use of CVP has to be treated as a dynamic variable. You can't use it as it's 20, I stop. Because it is it's a dose response thing. The more volume that you give, you check if the heart stretches. So if the heart is at 20 and then you give some fluid, the fluid did not stretch the heart stays at 20. So you can give more fluids. So that is what the experts in critical care are actually explaining to us in a convention that I attended. So you use a set point, your target, and you place a safety limit. Then you use the passive leg raise. So that is how you use it in settings wherein you don't have invasive lines or more devices.
Thank you, Doc. Thank you. For the last question, let's proceed to the neonates. Okay. So for neonates, is plain LR advisable to give during resuscitation?
I will have to beg off for the answer.
Okay,
I am
I
not
understand.
my specialty is adult critical care, so I have no experience regarding units. Thank you.
Okay. Thank you, Doc. Thank you. Okay, so now let's proceed to the awarding of certificates. Thank you, Doc.
Thank you.
Hindi ko nakikita yung Sorry for technical difficulties. So now let's proceed to the awarding of certificates. Next slide. So the Critical Care Nurses Association of the Philippines award the Certificate of Appreciation to Honorable Chairman LCT in grateful recognition as keynote speaker during the 2021 CCNAPI Annual Convention with the theme of We Rise, Resilience, Innovative, Strong, and Engage, given this February 23, 2021, signed by Diana Jean Serondo, overall chairman, and Mr. Erickson Batan, scientific chairman, and the president of CCNAPI, Maria Isabelita Sirogado. Thank you. Next, we award the Certificate of Appreciation to Diana Jean F. Serondo in grateful recognition as speaker during the 2021 CCNAPI Annual Convention with the theme We Rise, Resilience, Innovative, Strong, and Engage, given this February 23, 2021. Signed by the overall chairman Erickson Batan and the president of the CCNAPI, Maria Isabelita C. Rogado. Thank you, Diana. The certificate is awarded to Aaron Mark R. Hernandez in grateful recognition as speaker during the 2021 CCNAPI Annual Convention with the theme We Rise, Resilience, Innovative, Strong, and Engage, given this February 23, 2021, signed by the overall chairman Yana, the scientific chairman Erickson Batan, and the president of CCNAPI, Maria Isabelita C. Rogado. We also award the Certificate of Appreciation to Pfizer Sterile Injectables in grateful recognition for being our platinum sponsor during the 2021 CCNAPI Annual Convention with the theme We Rise, Resilience, Innovative, Strong, and Engaged, given conducted February 2023 to 27, 2021. Signed by Diana Jean F. Serondo, Anna Merly Amigo, the Ways and Means of Chairman, and the President of the Sinapi, Maria Isabelita C. Rogado. Thank you. For Dr. Robert BILKOVSKI, we award the Certificate of Recognition as a Speaker during the 2021 Sinapi Annual Convention with the theme We Rise, Resilience, Innovative, Strong, and Engaged, given this February 23, 2021, signed by Diana Jean Serondo, the overall chairman, Erickson Batan, the scientific chairman, and Maria Isabelita Sirugado, the president of the organization. Thank you, Dr. Robert. And we would like to uh, the Certificate of Appreciation to IDS Medical System Philippines Incorporated in gratitude for being our gold sponsor during the 2021 CCNAPI Annual Convention with the theme of We Rise, Resilience, Innovative, Strong, and Engaged, conducted February 23 to 27, signed by Diana Jean F. Sorondo, Ana Merly Amigo, and Maria Isabela Sirogado. Thank you, IDS, for your support. And for the moderators, we award the Certificate of Appreciation to Camille Lorraine D. Pilak in grateful recognition as moderator during the 2021 Annual Convention. Signed by Diana Jean F. Sorondo, Erickson Batan, and Maria Isabela Sirogado. And this is my Certificate of Appreciation awarded to John Christian Agustin, um, signed by Diana Jean F. Sorondo, Erickson Batan, and Maria Isabela Sirogado. Thank you. So this will be your certificate. This will the certificate of the participants. The CCNAPI, the Critical Care Nurses Association of the Philippines Incorporated, award the certificate of attendance for attending day 1, which is today, of the virtual series 2021 CCNAPI Annual Convention, Re-Rise, Resilience, Innovative, Strong, and Engaged, conducted February 23 from 9 a.m. to 12 noon with the Zoom ID number 921-1663-1911, signed by the overall chairman, scientific chairman, and the president of CCNAPI. But before we proceed to the evaluation, we would like to invite you to watch some of the videos of our sponsors. We'll be back.
At ICU Medical, we are in the business of making connections, human connections. We help to forge the human and emotional connections that are a vital link between patients and caregivers, that enhance clinical experience, and are the essence of outstanding quality of care. We connect patients and caregivers through safe, life-saving, life-enhancing medical devices. We connect innovation with empathy, empathy with technology, and technology with care. We connect answers to questions, outcomes to insights, and solutions to problems. We connect delivery and promise, care and cure. We connect people to hope. We are ICU Medical. When it comes to helping protect your patients from the risk of IV therapy-related bloodstream infections, every detail matters, especially the design of your needle-free IV connector. ICU Medical is here to help with the industry-leading Clave needle-free IV connector technology, chosen by more clinicians around the world than any other needle-free technology to help keep their patients safe. Since Clave technology is specifically designed to minimize contact between the connector's external surface and the internal fluid path, entry points for bacteria are minimized. In fact, in a comprehensive study comparing 20 needle-free IV connectors, researchers reported that connectors featuring Clave technology have a significantly lower bacterial transfer rate. And since Clave lets you use the same clinical protocol with every patient population, you can standardize on advanced needle-free connector technology wherever care is given. Why settle for less? See how you can upgrade your IV therapy with advanced Clave needle-free IV connector technology today by visiting www.icumed.com/clave. The desire to help people is at the core of every healthcare organization. At ICU Medical, we demonstrate this commitment by providing products and services that let clinicians focus more on their patients and less on the technology they use to care for them. We call it clinical excellence, and our Plum 360 infusion system provides a direct connection to help you achieve it. The unique design of the Plum 360 infusion system creates a direct connection for secondary infusions. This smart delivery method eliminates the risk of common secondary setup errors that have been shown to occur in 48% of secondary infusions, allowing secondary infusions to be delivered independent of head height, and helping to ensure that every milliliter of medication is administered and that infusion records are accurate. This direct connection even allows you to simultaneously deliver 2 compatible medications at independent rates through a single line, something no other pump on the market can do. As you begin to program your infusion on your Plum 360 with ICU Medical MedNet software, you're brought directly to the drug list, which helps to ensure that the limits set forth in the drug library are utilized, maximizing your hospital's investment in safety software and greatly improving drug library compliance throughout the facility. When it comes to air management, the Plum cassette can trap up to 1 milliliter of air before sounding an alarm, which results in fewer potential therapy interruptions. If the alarm is triggered during a primary delivery, air can be removed quickly and easily through a direct connection to the secondary administration port without disconnecting the line from the patient. This helps to limit exposure to hazardous medications, reduce the chance of contamination, and minimize wasted medication. And finally, when you and your electronic health records partner are ready, so is the Plum 360 with ICU Medical MedNet software. Our IV-EHR interoperability solution automatically populates your Plum 360 infusion pumps with medication orders direct from the pharmacy and sends all infusion data directly to the patient's electronic health record, resulting in fewer opportunities for programming errors, more accurate and timely documentation, and more efficient workflow. Why invest in anything less? You get more than a smart pump in the Plum 360 infusion system. You get a direct connection to clinical excellence.
Our priority, number one, is our boss. Our boss is not the stockholders. Our boss are our customers, the hospitals.
Since we are dealing with saving lives, we have to ensure that we give best quality products to our clients, to our hospitals. What we're looking for are top-of-the-line technology that we could bring to market and we could introduce to upgrade the Philippine healthcare industry.
We want to make sure that we tailor fit whatever our customers need. We do not say, this is what we're offering, take it or leave it. We talk with the hospitals, with the doctors. What do you really need? What are you looking for? What else will make you be more satisfied?
The most important thing is the after-sales service, being reliable and with sense of urgency because we want to earn their trust.
We really have to make sure we continuously visit our customers, not to change whatever we delivered, but to add on, to look at what their needs may be. That's why it's not after we make a sale, o sige, goodbye already. No, they continuously go and visit the customers.
Of course, partnering with the best of the best also is a big key factor to that. Xavier Medivices being trusted by these distributors, by these principals to carry their product, I think carries great value also to the hospitals.
In order to achieve a quality service, we give high importance about the professional and technical skills of our associates. That's why we are conducting a continuous training, mentorship, and workshop for the continuous professional growth of our associates in order for us to deliver an outstanding output.
What I only did is to make sure that there is continuous training for all our staff. Professional growth is very important to us.
The most fulfilling part of my job really is to help my colleagues grow. There's a lot of potential in them and bringing out their potential, for me, that's very fulfilling.
We at Xavier Medivices believe in building a future together with cutting-edge technology to accelerate Filipino healthcare.
Today, so this is the link for tomorrow's event. You can take a picture, you can screenshot this, or you can visit our website, www.ccnapi.org. The links for day 2 to up to day 5 are posted there. Okay. Now, before we end, I would like to explain the raffle draw mechanics. So there's a raffle that will take place on the last day. The raffle will be conducted on the last day of or February 26th during the closing remarks. There will be questions that the participants must answer in the Google form that can be accessed in this link. The questions will be taken from the convention sponsor page of the CCNAPI website. This page is open 24/7. So we really advise you to visit our sponsor page at the website. The answers are all there. Also, some of our um some of our parties sponsors have games. So may sarili silang games doon. So enjoy. Please visit and navigate the sponsors link to get the correct answer for the questions. Those who can answer all questions correctly will be included in the raffle draw. For the prizes, first prize will receive 5,000, second prize 2,500, third prize 1,000. And we also have 25 consolation prizes, 10 GCash worth 150, and 15 Starbucks GC certificate amounting 100 each certificate. For the evaluation and certification mechanics, accomplish the evaluation for the pre-convention through the links provided. This link will be open until February 24, 2021, 11 a.m. So until tomorrow, 11 a.m. After you have accomplished the evaluation, please wait 7 to 14 days to receive your certificate of attendance. For the main convention, February 23 to 26 has a PRC bond accreditation application for 10 credit units. You can get the full 10 CPD units when you complete the 4 days webinar. So you need to attend from February 23 to February 26 to get the 10 CPD units. Also, at the last day, after you have accomplished the 4 evaluation form, you're going to have a post test. Next slide. So this is the evaluation link. You have until tomorrow to answer this. So for more details about the convention, please log in at the www.ccnapi.org. So thank you everyone. I hope to see you again tomorrow and stay safe.
At ICU Medical, we are in the business of making connections, human connections. We help to forge the human and emotional connections that are a vital link between patients and caregivers, that enhance clinical experience, and are the essence of outstanding quality of care. We connect patients and caregivers through safe, life-saving, life-enhancing medical devices. We connect innovation with empathy, empathy with technology, and technology with care. We connect answers to questions, outcomes to insights, and solutions to problems. We connect delivery and promise, care and cure. We connect people to hope. We are ICU Medical. When it comes to helping protect your patients from the risk of IV therapy-related bloodstream infections, every detail matters, especially the design of your needle-free IV connector. ICU Medical is here to help with the industry-leading Clave needle-free IV connector technology, chosen by more clinicians around the world than any other needle-free technology to help keep their patients safe. Since Clave technology is specifically designed to minimize contact between the connector's external surface and the internal fluid path, entry points for bacteria are minimized. In fact, in a comprehensive study comparing 20 needle-free IV connectors, researchers reported that connectors featuring Clave technology have a significantly lower bacterial transfer rate. And since Clave lets you use the same clinical protocol with every patient population, you can standardize on advanced needle-free connector technology wherever care is given. Why settle for less? See how you can upgrade your IV therapy with advanced Clave needle-free IV connector technology today by visiting www.icumed.com/clave. The desire to help people is at the core of every healthcare organization. At ICU Medical, we demonstrate this commitment by providing products and services that let clinicians focus more on their patients and less on the technology they use to care for them. We call it clinical excellence, and our Plum 360 infusion system provides a direct connection to help you achieve it. The unique design of the Plum 360 infusion system creates a direct connection for secondary infusions. This smart delivery method eliminates the risk of common secondary setup errors that have been shown to occur in 48% of secondary infusions, allowing secondary infusions to be delivered independent of head height, and helping to ensure that every milliliter of medication is administered and that infusion records are accurate. This direct connection even allows you to simultaneously deliver 2 compatible medications at independent rates through a single line, something no other pump on the market can do. As you begin to program your infusion on your Plum 360 with ICU Medical MedNet software, you're brought directly to the drug list, which helps to ensure that the limits set forth in the drug library are utilized, maximizing your hospital's investment in safety software and greatly improving drug library compliance throughout the facility. When it comes to air management, the Plum cassette can trap up to 1 milliliter of air before sounding an alarm, which results in fewer potential therapy interruptions. If the alarm is triggered during a primary delivery, air can be removed quickly and easily through a direct connection to the secondary administration port without disconnecting the line from the patient. This helps to limit exposure to hazardous medications, reduce the chance of contamination, and minimize wasted medication. And finally, when you and your electronic health records partner are ready, so is the Plum 360 with ICU Medical MedNet software. Our IV EHR interoperability solution automatically populates your Plum 360 infusion pumps with medication orders direct from the pharmacy and sends all infusion data directly to the patient's electronic health record, resulting in fewer opportunities for programming errors, more accurate and timely documentation, and more efficient workflow. Why invest in anything less? You get more than a smart pump in the Plum 360 infusion system. You get a direct connection to clinical excellence.
Dalex Pharma International is a Filipino-owned and managed pharmaceutical and medical device company with the aim to bring affordable and quality medicines in the ICU setting. Home of Dalex ICU Forum, a train-the-trainers program to raise the standard of critical care practices. Your prescription doesn't just save lives, but they transform lives to our CSR program. Care LGL and Dalex Pharma introduce NeutraClear, a completely transparent neutral displacement connector that prevents catheter-related bloodstream infections. Its exclusive design guarantees that best practices are followed and ensures patient safety. NeutraClear's smooth, flat septum makes it easy to disinfect. The guiding seal ring protects needleless connector's integrity. Its 2.8 centimeter size and 1 gram weight reinforces care comfort in neonatology and pediatrics. The neutral displacement design prevents blood reflux in the catheter. Thus reduces the risk of occlusions and infections in the catheter. Its completely transparent needleless connector ensures best hygiene practices and is recommended by experts for effective flushing. NeutraClear, the closed system which guarantees neutral displacement and complete transparency to prevent catheter-related bloodstream infections.